Meanwhile, let's get started with today's grand rounds. Thank you very much for joining in. I'm going to just first share the slides to take you through the ability to get the credits for the CME and the MOC. And then subsequently, we'll have a nice introduction. So today's cardiology grand rounds, again, will be hosted at the YouTube website for the division, where you will be able to go back and watch it and share with others who have not been able to join. For today's CME credit, please text 17019 to the number 888-816-4893. 17019. Now it's the time to text 888-816-4893. Please make sure that this is a SMS message and you have an active profile on the Cloud CME platform. And to avail maintenance of certification, please do the step 1. And then at the completion of the lecture today, there will be this link that will be again displayed back into the chat box. You'll be able to get the link, and the room code is future 40. Future 40. You have 3 answers to be given to 3 questions. And if you answer them correctly and you have an existing ABIM ID that matches to your Cloud CME profile, then you get a direct CME and MOC credit to your ABIM ID. So with that, I'm going to go ahead and introduce our guest speaker, Dr. Neil Weissman. Dr. Weissman is a close friend, colleague, mentor. I've known him for several years now as I've worked at the American Society of Echocardiography and really cherished the relationship. He's the Chief Scientific Officer for MedStar Health and President of the MedStar Health Research Institute. He's the Professor of Medicine at Georgetown University School of Medicine and internationally acclaimed for his expertise in cardiac ultrasound and also his expertise in clinical trials. Particularly, he has played a monumental role in core lab activities in echocardiography and intravascular ultrasound. Dr. Weissman received his medical degree from Cornell University in New York, and he completed his residency and chief residency in internal medicine in New York Hospital. Following this, he completed his fellowship in cardiology at University of Massachusetts General Hospital in Boston. And then he moved on to Georgetown University School, where he has been in multiple roles, leadership roles, first as director of Ecolab, subsequently with the development of the ultrasound core laboratory, which has flourished subsequently. He also played monumental roles in the cardiovascular disease training program, and he rose to the leadership post of vice president and currently the president of the MedStar Health Research Institute. And since 2018, he's a chief scientific officer, where he provides leadership for development and implementation of scientific priorities with a commitment to advancing MedStar Health as an academic health system. He has been in multiple committees nationally at American College of Cardiology, American Society of Echocardiography, National Board of Echocardiography, FDA, to name a few. Specifically to mention, he's been the chairman of the Guidelines and the Standards Committee at the American Society of Echocardiography. And also he was the president of the American Society of Echocardiography in 2015. He has over 350 peer-reviewed publication and textbook chapters on clinical trials in valvular heart disease, intravascular therapeutics. And he has served as a principal investigator on numerous national and international multicenter trials. And more importantly, he has mentored several people, including me, through my formative years in the early part of my professional development at the American Society of Echo. He's an innovator, and he likes to work with innovators. So I've also enjoyed working with him on several national initiatives, including his visit when I was at West Virginia University. So Neil, welcome and look forward to your presentation today.
Well, thank you very much, Partho, for that kind introduction. And I want to congratulate you on everything that you're doing there. It's just phenomenal, and I look forward to hearing great things coming from the hospital. So we could go to my slides there. Can you see the slides?
Not as yet. So
okay. Hopefully they will be.
You can share it, Dr. Weissman. Yes.
I have to share again? Okay. Okay. Oops. Let me just go back. Here we go. Okay.
yes, we can see it now.
Great. Yeah, sorry about that. We had set it up ahead of time, and I thought it was still there. So thank you again for the invitation. So this lecture, it's kind of interesting, Partho, as I listened to you go through my bio, it's like, you know, first thing is, oh my God, I'm old. I've been around here doing a lot of stuff. The second thing is this lecture is going to be probably unlike any of the cardiology grand rounds that you've had. And you're going to see why pretty soon. But there is some cardiology in it, but that's not really the focus of this lecture. By way of disclosure, you heard I founded an EchoCore lab, and we have multiple sponsors, but it really has absolutely nothing to do with what we're going to be talking about here. It is background, and I'll use some examples, but that's it. So with all good grand rounds, you often start with a case presentation. That's how it used to be done. So I'm going to give you a case presentation, but instead of a patient, I'm going to talk about a population. And we are very, very fortunate to live in the nation where innovations are created, where we're on the cutting edge. But can you imagine if you lived in a world where there was no modern healthcare? And I pulled some statistics from this world. The average life expectancy, 58 years old, when at the time of this data, the average life expectancy of an American across the United States was 73 years old. And if you don't, you could look at a number of diseases in this area. I'm going to show you, but I picked one which was HIV. And in a 2-year period, HIV, something that when I was a medical student, we were discovering have effective treatments, diagnosis, everything. In this world, even infectious diseases like this have doubled in a 2-year period. It's terrible. It's atrocious. You would never want to live in a place like that. But that data that I just gave you is from my own city. It is data from Washington, D.C., east of the Anacostia River. So I'm going to come back to that. You might be asking yourself, who is this guy and what the heck is he talking about? So I'm going to go back to my bio because it's relevant for this lecture. Yes, I trained in classic university hospitals, academic medical center. There's Cornell, New York Hospital, and Mass General at the top. I moved to what we call here the Hilltop in Georgetown. It's on top of whatever hill is in Washington, D.C. in the 90s. So all very traditional academic settings. But now I am responsible for research across a health system. That health system spans the Washington-Baltimore area. It has about 300 physical locations. 10 of them are large acute care hospitals, but hundreds of other locations. And this healthcare system is been in evolution. It's about 20 years old, has the same CEO for the last 15 years. And we function as what's called one MedStar. We always talk about it so that you can walk in any door and you're going to get that same experience, that it's fully connected. And in this setting, I'm responsible for the research. So we currently have research at about 40 sites. We have about 400 physicians involved in the research, about 1,000 MedStar associates, and produce approximately 100 peer-reviewed publications per month. So, but it's across the system. It's very different from doing research in one building. So that's the relative background for this lecture on redefining the academic health system from a guy who is an academic cardiologist trained in classic settings who now got plucked down in this system that's sort of under development. And what does it all mean? Well, let's go back to our case study, our population case study of the terrible health statistics east of the Anacostia in Washington, D.C. And by the way, I could pick lots of other cities. I could pick Chicago. I could pick Atlanta. Lots of places that there's a huge disparity in healthcare. And you could just see, I mean, chronic diseases, heart disease 3 times more, cancer 2 times more, and so forth. And the question really becomes, well, if we live in one of the richest nations in the world, with one of the best healthcares in the world, with one of the premier academic institutions that everyone around the world wants to come to train, how the heck did we get here that in our nation's capital, we have such poor health for such a large sector of our community? And what role did academics play? So how did we get here? How do we get closer to an ideal state with health equity? And what role can an academic health system have? And where I'll pull together some of the work that I know Partho has brought there, is how can disruptive innovation and technology help us achieve our goal? So that's what we have in store for the next 45 minutes or so. So we know that contemporary medicine is based on university hospitals. Now, more so, we say academic medical centers, because not all are based with universities. We have a tripartite mission. And again, at large clinical centers, that don't always have university in name, like Cleveland Clinic or Mayo. It might be more like a tricycle than a 3-legged stool, where the clinical care, when you walk around the halls of Cleveland Clinic, the clinical care predominates, but it wouldn't be what it is today if it wasn't for research and academics. Academic medical centers are the birthplace of translational research, and particularly T2 of transferring those findings to the clinical practice. So that all sounds great, but nonetheless, we're in this situation of this great disparities of healthcare, even in the setting of great academic medical centers that are translating clinical findings to practice. So what happened? How do we get this disconnect from this premier academic medical society that we have all benefited from, and this poor healthcare that so many people in our nation have? Well, the answer is pretty simple. Academic medical centers are really, really good at being academic, focusing on medical, and being a center. So let me explain that. So I was having a conversation with our general counsel, and he had just come to us from a large commercial, a large industry, non-healthcare industry. And I was talking about the virtues of academics. When I say academics, when you hear the word academics, it's a positive thing. We're proud of it. When he hears academics, he says, when I'm in a boardroom and somebody puts forward a theory or an argument, a rationale, and somebody else says, oh, that's just academic, that's the biggest insult in the world, because that means that what you just put forward in the boardroom is disconnected with reality. It's not realistic. It's not feasible. It's not connected. You're off and just being academic. Academics has, in large part, gotten disconnected from the realities that exist out there in healthcare. I remember hearing a presentation of a good friend of mine that's at Mayo Clinic, and it's work that he had been working on, oh my God, at least 10 to 15 years. And I'm sitting in the audience, I'm feeling really proud for him. And the person next to me, who I didn't know in the audience, leaned over and said, oh my God, that's never gonna work. And I was like, what do you mean? He just proved that it worked. He just went through the study. He proved that it worked. And he goes, no. I know technically it can work, but it's never going to work for me. I'm not going to have that amount of time to do all of those strain measurements. It's never going to happen in real life. That was an example of being academic. And sometimes we develop things that don't get implemented because there's issues in feasibility. Medical, academic medical centers, including the training that you and I have gotten, is all about medicine, diagnosis, and treatment. But we know that even that as physicians, we practice medicine. We go in and say, what's the problem and how do I fix it? As a person, as a receiver, what we want is to be well. We want to feel healthy. We don't want to get sick. So we actually are talking two different languages. We have to recognize that what business we're in, and we're in the healthcare business. We're not just in the medical business, because the clinical care only accounts for 10% of your health. There's a ton of things, social, economic, behavioral factors. And we know that because when it comes to us, ourselves, we take care of ourselves. We eat right, we exercise, we don't smoke, we do all those things. But we're practicing diagnosis and treatment. And that's what academic medical centers have focused on. And then lastly, but probably among the most important, we're very egocentric. We expect people to come to us. We're at the Mecca. We depend on referrals. And the majority of healthcare is not happening in the four walls of our hospital. It's only when it gets to a critical level that it gets into the four walls of our hospital. And then we got all the problems of the center, limited space, resources, and so forth. So that's part of the explanation. And you could kind of see how academics and academic medical centers has not addressed the inequities that happen in our healthcare. So what can we do? What's the solution? And can academics get reconnected with all the people in our broad community and reoriented to focus on health to help drive the changes that we need? So short answer is yes, absolutely. There's absolutely no reason that academics can't drive improved health for everybody. What we need to do is redefine what we're doing and redefine the academic medical center. So I'm saying that there's two steps just to break it down. There's two components. It's not that you have to do step one before step two, but the two components are to change our view of being a center to being a system. Okay, so moving from an academic medical center to an academic medical system. We have to recognize that to really serve the whole community, we have to get out there and have multiple points of access for the community. We have to recognize that our community is diverse and has different needs in different places. And the care that we deliver is going to be diverse, different types of practitioners, different types of settings. We have to focus on research, the creation of knowledge to deliver better care. You know, it's not just, is it the red pill or the blue pill, but it's how it's delivered. What is the best method? Look at, we saw over the last couple of years, the growth of telehealth. That's just one example. And this whole field, as a cardiologist who did research for 20 years before I took my current position, to me, research was either new drugs, new devices, but health services, research on the manner in which we deliver health and implementation science really is going to have a greater effect than just another new drug or new device. So that's moving from an academic medical center to an academic medical system. It's the use of health services research. There are entire federal agencies, AHRQ, the Agency for Healthcare Research and Quality, that focuses on this. Their whole methods is to improve the quality of healthcare, make it safer, make it more accessible and more affordable. And implementation science, another area that I was not familiar with before coming into my current job. It's all about the fact that some things that are proven to work don't work in different environments. And it's not because of the technology or the drug or the biology. It's because of the delivery, that there are a lot of obstacles to that delivery. It's multifactorial. Implementation research involves not just the person that created something, but those that have to deliver it in a broad sense, not just doctors and nurses, but sometimes it's technicians and environmental service workers and other things. So it's really looking and focusing on understanding how change takes place. And if you do all of these things and move to an academic medical system, you will get the state-of-the-art evidence-based medicine in the community at the highest academic standards throughout the whole delivery network. So it's really moving from not just T1 and T2 to T3 and get it into the community. So that's moving from an academic medical center to an academic medical system, but we have to recognize that we need to become academic health systems. Changing the focus from just medicine to health, which includes medicine, but includes all the social determinants of health. Again, it's what we want as an individual. It's what everyone else out there also wants, and that's what we need to focus on. So to do this, and to start addressing the social determinants of health, which we have not been trained to do, we have to first recognize we haven't been trained to do it, involve those that have been trained to do it, public health, social work, and so forth, and figure out a way to get embedded in the community, because these things that affect the health are not happening in the four walls of the hospital. This is a complete paradigm shift. It is not what we have focused on. It's not how we get reimbursed, but it's what we need to do if we're going to move the needle in terms of the health of everyone. So this is a little cartoon we use at MedStar. It talks about the health system and how we're all connected, and you could walk into the urgent care and that information from your hospital stay would be there, or your wellness visit or whatever. We have a big helicopter service, and that's why it shows a helicopter, and then Georgetown is over to the right. And we've partnered with our university partnership, and not just the medical school part of it, but the law school, and that's what O'Neill Institute, the School of Public Policy, because that's what you have to do if you're going to affect the social determinants of health. So all this sounds nice and good, and yeah, we should definitely affect, the community health and be connected. But how the heck do we do that? I remember when I gave some part of this lecture for the first time at a board meeting, somebody said, yeah, Neil, that all sounds good, but it's all academic. So they used my own words right back at me. How are you going to do that? And I was like, I think we can. Well, how are we going to do that? And this is where it gets exciting. And this is where I've been able to connect my worlds as a healthcare administrative executive and as an academic cardiologist. Because the way we get embedded in our community is through disruptive innovation. So let's take a step back, maybe a step to the side, and just make sure we're on the same page. What is disruptive innovation? What are examples of it? And how do we apply it in cardiology to get to redefine the academic health system? So disruptive innovation, Clay Christensen wrote a number of books and really helped drive this terminology. It's a new technology that unexpectedly replaces an established technology. It's better in price and size and usability. It's why we use Uber instead of taxi cabs. There's lots of examples out there, but one of my favorite is Kodak. I grew up in the era that there were the little yellow boxes of disposable cameras and film. In 1970s, 90% of film and 85% of cameras sold in the United States were Kodak. And then 40 years later, 2006, a corporate video, and I'm going to just play this because it's fun. This is all I gave an Edler lecture at the American Society of Echo. So Partho has seen this before, maybe some of you, but it's fun. It's only a minute long. So this is from Kodak's corporate video in 2006.
For more than a century, the Eastman Kodak Company has been part of our lives, our memories, and our futures, continually pioneering technologies that make the process of taking pictures easier and the results remarkably better, allowing us all to share the precious moments we treasure, the benchmarks of our lives, with those we love. In fact, many of us fondly refer to those special times as Kodak moments. Kids growing up, puppies playing in boxes, elderly people blowing out birthday candles, daddy's little girl becoming a blushing bride. Gets you misty, doesn't it? Yep, they shovel the schmaltz on pretty thick. But that kind of crap doesn't work anymore. People want the latest digital things, more power, more features, wireless contraptions, innovative ways to bring their pictures into the 21st century. Well, guess what, bucko? Kodak is doing it. You thought they were just hiding out, waiting for this digital thing to blow over, didn't you? Oh, sure. For a while, they were like, oh, there's no way digital's going to catch on.
Well, that was 2006. We know how this story ends. Kodak goes out of business, files for Chapter 11, 6 years after this video. And the remarkable thing, whoops, I'm not sure what, the remarkable thing is that Kodak invented the digital camera 40 years before that, 50 years before they went out of business. But they put it on the back burner because they didn't want it to undermine their main business, which was film and camera. I showed my son this, he's 21 years old, and he was like, what the heck is Kodak? It didn't mean anything to him. So we all know he remembered Blockbuster when he was a kid, and we know the whole story about Blockbuster, how they went under. But the guys who pitched a way to do DVDs by mail went on to found, they were kicked out of the boardroom because Blockbuster would lose $500 million a year in fees and late fees. They were kicked out of the office. They started Netflix, and clearly Netflix continues to reinvent itself. So it's another good example. So why does this happen, and how does it relate to us? Now, as I said, I gave this as the Edler lecture about 5 years ago, and really was making the point that we need to make sure that we don't pass on new ways to do things. We're all busy. Life is hectic. The industry tends to focus on what we know and can do best. We tend to focus on what we know and we can do best. And the times that companies are most vulnerable to disruptive innovation is when they're most successful in what they're doing. It's difficult to recognize the need to think differently when you're not in a crisis, things are going okay, everybody needs you. Well, that's the time that you're, again, really a setup to do things differently. Because if you're that busy and they need you that much, someone's going to come up with a way to do things that are more efficient and maybe don't need you quite as much. And that's what I was saying. Echo is at that stage. We're either going to get disrupted or we need to be the disruptor and do something differently. 50 years of success in echocardiography, enormous advances in technology. But when you look at them, they've been incremental in how it's applied. And then lots of growing external factors. So I like the little sign there, to avoid injury. Don't tell me how to do my job. Just let me do my thing. So disruptive thinking is about doing the work of a crisis before the crisis really exists. And that's where Echo is right now. There's a great book by Luke Williams called Disrupt. think what no one else is thinking and do what no one else is doing. And it goes through and helps people when they're not in a crisis to step back and think about what is a better way to do things. And he proposes just ask three basic questions. What business are you in? Who's doing that business? And what's the best way to do that business? So let's do that for echocardiography. So what business are we in? Oh, this was just, when I say what business are we in, your first reaction might be, what do you mean, Neil? Obviously, we know what business we're in. Well, no, I don't think so. Kodak thought they were in the camera and film business, but they weren't. They were in, I want to capture that image. Maybe even I want to capture that memory business. Blockbuster thought it was in the video or DVD business, but they weren't. They were in, I want to watch a movie business. What business are we in? So, as echocardiographers, are we in the business of creating great images with cardiovascular ultrasound? The imaging business? Yeah, I think so. But that's not it. That we also need to interpret those pictures, right? So we interpret those pictures and we could see things that everyone else can't see. So is that the business we're in? Yes. But that's not really the only business we're in, because we know that people are going to come to us and ask us about that interpretation in a clinical perspective. So we help them because we don't just say the left atrium is large or the LVEF is 20%. We help integrate that information. We analyze it and integrate it into a new diagnosis, heart failure, and help guide therapy, whatever you're doing. So that sounds a lot more like what it's like to be an echocardiographer and reading echoes and interacting with the people that order the echoes, right? So that's the business we're in. Or is it? Well, if you step back, if you're a patient, what are you going to the echo lab for? You're going to the echo lab to be taken care of. And that's really the business we're in, right? And we know that when we're not just reading echoes, but that is the business that we're in even when we're doing an echo. And again, none of this is rocket science, but it's important to step back and ask yourself what business you're in. Then, if it's in the taking care of people with the use of ultrasound, who else is in that business? Well, I love this little quote. That's Jerry Garcia on his 75th birthday. I want to be rocking when I'm 75. He has this great quote that I like, which says, you do not merely want to be considered just the best of the best. You want to be considered the only one who does what you do. We want to be considered the only one that does great echocardiography, but we know very, very well there's a lot of other people doing that. I don't know about your medical school, but my medical school incorporates it into the curriculum from first year on to do ultrasound. It's going to be like an EKG. Everyone's going to have basic understanding and application of it. So we're in the business of taking care of people. We're training lots of non-cardiologists. At the time that I gave this lecture, there was a great editorial, President's Page, by Susan Wiggers, that again brings us back to the patient perspective. Is it a good idea to do point of care? Well, no denying if I was the one that was sick and in the emergency room, I'd want somebody that knows what they're doing there to help take care of me. So of course, we're there. Now the question becomes, what's the best way to do it? We know technology is giving us smaller and smaller probes. We know that this technology is going to keep on going and things are going to get easier, smaller and easier and cheaper. And you might say to yourself, yeah, you could have a probe that fits on your finger and it's in your pocket and we have them now, but people don't really know how to use it. But we know that, and you guys again have the experts there, things are changing. And with Moore's law and the doubling of processing every 2 years in terms of size, so that we've got more computer power in our iPhone that was in Apollo 11, we know that AI, machine learning, is being the game changer. And this is going to be a game changer and feed our disruptive innovation. This is from, I guess it's almost 2 years now, where Caption and Butterfly came together and really can make it so that the novice can do an echo and interpret it. For those that are not familiar with Caption, used to be called Bay Labs, it's essentially a GPS-guided echocardiography that it used machine learning to say, if I have this picture, what do I need to do to get a good picture? Do I need to turn left, turn right, angle up, angle down? It gives a screen like this. Up in the top left is a little a meter that gets better and better as you get closer and closer to the good picture. It gives directions, angle down, slip down one rib, turn to the right, turn to the left, and it's doing some automatic EF measurements. I was involved in a study from about 2 years ago that we looked at this. We randomized 240 patients at 2 institutions to get an echo by a sonographer, an experienced sonographer, or by a nurse who had 1 hour of training of how to get an echo. And lo and behold, with this GPS type of system, we got great results. The novice was able to get a diagnostic quality image in over 90% of the time, and the measurements were very close to the interpretation of those images was very close to the sonographer. This is from one of my colleagues in South America. And what's so cute about this, well, it's just cute. There's no denying it. But his daughter, he did not teach his daughter to do this. His daughter was watching her dad do this and practicing with this new handheld probe that he got at home. And she was like, I want it, Daddy. I want it, Daddy. And she took it and started doing this. Not yet there, but a cute picture nonetheless. So you could get the images, but can you interpret the images? And the answer is, yeah, it's happening. And again, Partho has been one of the leaders in this field. There are now, if not dozens, hundreds of studies out there that have shown that you could do AI and machine learning for interpretation. This is from my colleague, Federico Ash, and working with Roberta Lang at University of Chicago with the WAVE study, the World Alliance of Echo Societies. It was 2,000 patients where using AI algorithms could identify accurately what image it was, can use it if we want to stack images, say, give me all the images that show the mitral valve, and present it in a way to decrease the reading time, use it to do measurements versus expert core lab measurements, and use it to just show improved efficiency. If you run it through the algorithms before you present it to the reader, how long does it take them to interpret that echo versus without that assistance? So it's faster, cheaper, quicker, easier, and quite frankly, more accurate. You could see there was less variability. So we're getting there. And it's moving pretty quickly that we're going to be doing more and more AI-assisted interpretation. I think that's going to come first, but the acquisition is already happening and got a uptick during COVID when we needed novices in ICUs to do some images. So I like this little quote. It's from a radiologist, but I think it applies well to our field. AI won't replace, you could say, cardiologists, but cardiologists who use AI will replace those who don't. I often, when I'm giving the lecture in person, I talk about when I fly home tonight, I want to be on a plane that has a pilot. I'm not ready to get on a plane that just has autopilot. On the other hand, I want to be on a plane where the pilot has autopilot, because I know it's going to make them a better pilot. It allows them to rest when they could rest and has an extra set of eyes. I have to say, I got a new car last summer, and it's got great automatic features. Even when I'm driving, I put them on because it makes me a safer and better driver. So that brings us back to Butterfly, the handheld $2,000 probe. They want to get it down to $500. And Caption Health. And will this democratize echo? First time I heard the owner of Butterfly talk about democratizing echo, I wasn't really sure what he meant by that. But he went on to explain that he wants this echo probe in every home. Just like everybody has a thermometer in their house, he wants to see the day when everyone has a probe in their house, an ultrasound probe that could help them. So it is widely accessible. And while we're, in my opinion, far from there, we definitely are at the stage where less and less experienced people can get good images, less and less experienced people can have accurate interpretations for the common things. But this idea of democratizing it, of getting it into everyone's home, really got me thinking and connected my cardiology world with my healthcare executive world. I read Modern Healthcare. It's a trade journal that comes out every week to executives across health systems. I promise you, the president of your hospital is reading Modern Healthcare. And they had a front page story not too long ago about the hospital in the home. It is predicted that 25% of what currently happens in hospitals and clinics is going to happen in the home by 2025. That's crazy. 25% of the stuff people have to come into a clinic is going to happen in the home. It got me back to my little illustration, my little cartoon. And what I never paid attention to was that satellite beaming things down into this community. And I actually think, lo and behold, somebody maybe didn't realize how important that beaming down is. And this is where we really get disruptive innovation and really redefine an academic health system and really move the needle on health equity. We know pattern recognition. We're great at taking a picture of something and seeing what it is. Radiologists use it all the time. In the first year that this app for derm came out to look at skin lesions, it diagnosed 27,000 skin lesions, mostly in Europe and Australia. Right now, you could go onto Google Lens, which is great at identifying all kinds of things. You could take a picture of your skin, a skin lesion. It will ask you if you want to be in a study to say what that is. It's happening. And if you could do it actively by taking a picture, you could do it passively by building this technology into your bathroom mirror. There is absolutely no reason that your mirror can't be looking at your skin on a daily basis and looking for new lesions. There's absolutely no reason it can't be looking at the symmetry of your face and make sure that you didn't have a TIA or a mini stroke or something. There's a ton of stuff that you could diagnose just by looking. And if you think about that now, and think about what else can we do passively by using AI and machine learning, it goes pretty far. So let's stay in the bathroom. So you take a look in the mirror, then you use the toilet. When you get a urinalysis and you do a dipstick, there's no reason that technology can't be baked into a toilet with cartridges. And what else could it look at from your urine or feces? And what studies and tests can you do with a smart toilet? And I'm not making this stuff up. There are smart toilets out there that have cartridges that some that they're trying to sell commercially, most that are still undergoing development. Your toothbrush. Think about the information that's in your saliva, and everybody has a blood sample happening during brushing your teeth, okay? There is healthcare through your toothbrush that's happening, and even the aerosolized breath that it could take in. Again, this stuff is real. It's happening right now. And then if you want to get out of the bathroom, one of the things that I think is remarkable in terms of being a source of health information on an ongoing way, in a passive way, you don't have to do anything, in your home, is the whole idea of your Alexa and listening to you. So we're doing a study that's NIH focused. That's, to me, super simple. It's like a chat bot. It's back and forth, asking questions for patients that have heart failure and other things. And it's kind of an algorithm. And that's fine. Again, it's important to do. It's testing just voice versus using an avatar. But there is a whole world of using your voice as a biomarker. So I earlier today, I was on with a friend, and I was like, ooh, what's going on? Are you sick? We could tell if somebody's got a URI. By using your voice, you could diagnose a ton of things, especially if you have a baseline and look for change. And I've got them all listed up there. So this is a way that we could get connected to the community and embedded. And then it goes even further. If you look at some of these other things, let's just take physical environment, there is technology that's getting put into the clothes and can look for pollutants. So you could have something that's baked into the clothes that if you get exposed to a noxious gas or just high particulate content, it will turn red and let you know that what's going on. So these are ways that we could truly improve health. Let me end by just some work, and this is also a couple of years old, that with IBM, and it just looked at the different things that HSS laid out for the cognitive portfolio and what we could do. But the parts that I didn't know about before this was the idea of concept insight, sentiment insight, tone insight. By listening to me, you can know if I am mad at you or if I think you're really, really nice. You could look in my face. And if you could do it, we could teach do machine learning on it.
Hello, I'm Sophie, and I'm an avatar. I can share information, conduct surveys, and answer questions. Who am I speaking with?
And then if we personalize it and make it look like a person interacting with you rather than a machine, people are more receptive to interact. So I'm going to show you a little clip of somebody interacting with Sophie, the avatar. They're going to talk about their asthma. They're going to talk about the air quality index, AQI. And you'll see that it's going to be reading the person's tone from their voice and their face, using that information, pulling information from public sources, what's the air quality index there, to help treat this patient.
You had 5 asthma attacks last week, David. What's going on?
Not feeling well. I got a cold starting. Had to go to Barstow twice for work.
Barstow's nice and dry. What's your asthma keeping you from doing?
Yeah, well, normal life for starters. Like walk upstairs, play with the kids, go see a movie.
Okay, well, here's some weather for you. And I can't say it's nice out. Your neighborhood AQI is 160, humidity's down, and particulate matter's up, so you'll have a 65% increased risk of an attack today. You got some popcorn in the house?
Sure. I get it. Not going out today.
Right. And keep your Advair inhaler nearby.
Okay. Every 2 hours I take 1 shot, right?
That's it. You want me to remind you when you need to take it?
Send me an SMS.
Okay. Talk with you soon.
So that's bringing healthcare into the home. So this is this whole area of digital therapeutics. And I never knew that term before a year ago. I just came back from the CVS Health Forum, where digital therapeutics was a mainstay of what they were talking about. CVS Health is investing big in digital therapeutics as they spread out to become a health platform. It's just, again, how do you deliver evidence-based therapeutic interventions that are driven by high-quality software programs? The first alliance of digital therapeutic alliance is happening in a few months. And what's really, really cool, and this is where I'm going to end, is that this concept of digital therapy, digital diagnosis and digital therapy can truly change the equity, can raise the health equity. This is a group that is all about using different digital devices and techniques to be inclusive of society, transforming the future of healthcare through digital solutions. So that's a pretty cool concept and gets us right back to redefining an academic health system through disruptive innovation. It's producing academics that's connected to the community, academics that's going to drive the changes that we need, and change that's quickly adopted, and promoting health equity because it's easy to use. It's a low barrier. It's in your home. Change that improves the health, not just medicine, but the health and well-being of all those through these passive ways to monitor health, to give feedback that, again, is accessible and affordable. And a system of care that transcends the walls of any clinic and extends into the home. So with this, I'm going to, for time, skip over that. I want to thank you for your attention. I appreciate it. This is just a little collage of the people that I get to work with every day in the core lab and that are doing most of the work that I presented. So with that, thank you very much. And Partho, I will turn it back to you.
Thank you very much, Neil. This was, again, a very important to discuss the future and how it's shaping up. And I think we're going to have some time for discussions. Yeah, so there are some interesting questions that are coming up. And before you could answer that, you can embed the answer to that question. I want to ask a very practical question. So let me posit to you that health systems go through change, and changes are very slow. We just got into Epic last year. And Epic is a different environment, and everything is based upon how we get reimbursed. I mean, we definitely want to take care of our patients, but also the practice and the way we are hostage to the way we practice medicine is also dependent upon these giants in medicine that are dictating how we are taking care of patients. Now, a practical question would be if you participate in this evolution or in this pattern of thinking, will it really translate into something equitable, like making more RVUs or making more reimbursements or making a better salary? And if that's yes, how soon is that change expected?
Yeah, it's the key question, right, Partho? Practical. Come on, I live in a practical world. So help me bring this together. Neil, you're just being academic. And you could imagine that there was probably a similar discussion in the late 70s when this digital camera was invented about we get reimbursed, we make our money by selling film and cameras. And Blockbuster probably had the same conversations, like we don't want to cut down late fees. That's not how our reimbursement works. That's not how we make our money with late fees. So I think that we have to recognize that we are in a place that our income is generated through this RVU system. But at the same time, we have to recognize that it's a little bit of a house of cards, and it's going to fall down once somebody comes up with something that really makes it so that other people are going to adopt it quickly. And that's only going to happen when you bring together the payers and the providers under one roof. So you can imagine, and this is happening, that the Kaisers of the world are adopting digital dermatology much faster than some others, you know? And I think as more and more payers and providers come together, we're going to see some of these more disruptive changes get rolled out. Particularly, I mean, I mentioned CVS. You know, CVS purchased Aetna. So now they're the insurance company, and they're trying to be the front door to healthcare. So they can, that's why they love these digital therapeutics. If they could push it out and prevent their people that they're insuring from having to go into the hospital, that's going to work. So I think that we're going to need to see different models, different financial models to move this forward. And it's going to be interesting because it's going to have to create some interesting partnerships. Now, some places, UPMC, Pittsburgh, they've got a big insurance platform, and that's how they're investing in it. So I think everyone's sort of looking at how to do this because it is going to change at some point. We're going to do what's best for the patient and most affordable, not just what we currently get paid for.
How soon do you think this is going to hit the mainstream? What's your guesstimate? What's the time horizon where everyone here, okay, we need to just start looking into different mode of seeing our patients, and this is a reality. And I think there will be a panic that will come up. But what is your estimate of the time horizon when the panic will strike?
I honestly don't know. But I think when it starts happening, it's then going to happen fast. Okay, so certainly, if I was at the early part of my career and just finished fellowship, it's definitely happening in that professional lifetime, without a doubt. Okay, but is it going to be in the next 5 or 10 years? I'm doubtful that there's going to be major sea change. I think we'll see some pots start to grow and areas that this is adopted quicker. But once the door opens, it's going to go fast.
Great. Neil, I'm going to ask you another question. In this world where research, there's no time for research and reimbursement for research, why should I be academic and do that?
You know, I think that comes from the heart, not from the pocketbook. I think the people that it's just what you enjoy doing the most. We all have practicalities. We all got to provide for our families. I get that. But you all see what burnout is like. It's happening all around us. Just make sure that each day that you're coming into work, there's something about that work that you're really enjoying and gives you fulfillment, because this is a marathon. For me, the academics gives me fulfillment, and that's what gives me the energy to keep going and be enthused about it and to continue to learn and grow. So that's the reason to do it, is for your own satisfaction, gratitude, growth.
So it's your hypothesis or your observation, Neil, that when you have in academics, you likely to withstand burnout better, or do academic people get burnout? Yeah.
There's been a number of studies. An environment with, I've done this and shown the data within MedStar, because we've got academic areas and we have non-academic areas. The academic areas have a higher quality of care, have better patient satisfaction, have greater engagement of the physicians, and lower burnout. So academics definitely can help drive a much better environment, clinical environment.
Right. There's a skeptical commentary. Is there any specific evidence that you know of that adoption of digital disruptive medicine makes a difference in health delivery and outcomes? Maybe that's what I would read that commentary.
Yeah. So I think we're gathering that data now. Mental health is probably further ahead than everything else. There's hundreds of studies in the mental health arena that and it's not just telemental health. It is using apps to help calm anxiety, and identify depression early and things like that. That have definitely, and there's companies that have been formed, and there's employers that are going right to these companies to provide these tools for them. So I think those are the areas, but I think there's many other pockets where the evidence is being developed now that it makes a difference.
I also picked up a very important concept that hospital at home is going to change 25% of how we practice cardiovascular medicine or maybe other medicine. How is it that you're adopting to this concept in your health system? What are you doing? What is happening?
So a big boost in what used to be called VNA, Visiting Nurse Association. So we have a whole VNA division of our healthcare system, and a lot of stuff is getting pushed there. And it's, by the way, it's not just nurses. There's a whole fleet of technologists and people that go into the home. Partnering up with device companies, wearables of different sorts, and connected simple things, connected scales so people could weigh themselves and things like that. The chatbots and using that for clinical things, not just for scheduling that they're typically done and schedule reminders or how to get a doc, but using it for some of the clinical follow-up for the patients. So those are the things that we're doing, which I think are pretty simple things at this point. I think the wearables and the devices in the home is going to be the wave that we're going to see increase a lot over the next 5 years.
And with regards to some of the diagnostic work, are you think that even the diagnostic is going to shift into homes, or what are your thoughts? I mean, your thoughts of patients doing their own samples or imaging, and that's very disruptive.
Yeah, I think it is going to shift into the home. I think when you say sampling, it depends on what type of sampling you're talking about. If it's saliva, it's not a big deal. But I'll tell you, things that I didn't think were going to be accepted by patients are being accepted. So we did a COVID study, sort of a surveillance study, an epidemiologic study with a number of other hospitals. We enrolled 16,000 MedStar patients strictly through the patient portal and an e-consent. And they had to log in every day on their phone what their symptoms were. Then we would send them a little finger prick to do a blood sample for seroprevalence and antibodies. And we had remarkable 80-something percent of compliance that people would stick their finger and do that. I was blown away. Now, the motivation was there because it was before there were COVID tests and everything else, and they wanted to know, have they been exposed and do they have antibodies? But I think there's a lot more stuff in the home that people are going to be willing to do.
And Neil, one more thing I wanted to ask you. You are the president of the Research Institute. Growingly, we know that to do research, there is lesser and lesser time that is available. What is your average protected time for people who are involved in research in your health system, for physicians?
So this is a terrible situation we're in nationally. We're all being squeezed for more RVUs, and academics is definitely getting squeezed out. I'm in a large system where the majority of the physicians are not academic. They did not come here. So we have a minority. I think I showed you, if we've got 4,000 physicians, we have maybe 800 that are involved in research, so 20%. So that's the first thing. So you're embedding academic people with a lot of people that they chose a career that's a clinical-based career, and then amongst those are the ones that we work to make sure they get protected time. But we work at it, and it's not easy, and it gets threatened all the time, and have been able to make establish some programs that people could apply to that show accountability, that they're using their time well. And if they use their time well, they can keep getting it or get more of it. but there's a lot of people that haven't used their time well, and they drop off and increase their clinical. So again, it's a little different than a university hospital setting where everyone comes there because they're academic. But what it's doing is essentially making, academics is a specialty unto itself in a big clinical environment.
So I think these are the realities of the modern existence. I think, but I still feel like if you have an excitement and an urge and a passion to be part of something new and different, you could find your way to be able to be part of it. And sometimes you never look for the time, but you just are part of the journey.
And sometimes you do it through collaboration. You know what I mean? That a clinician educator often is educating contemporaneous with taking care of patients. And there's ways that you could be part of a team, part of that milieu, contributing to science, but you chose not to be the principal investigator on it. And that's beneficial to everyone. But there's got to be somebody who's the principal investigator and having some dedicated time to it.
Yeah. Fantastic, Neil. That was wonderful to get your thoughts on how to navigate through this transitional and very challenging period. And evolution is and changes are always difficult, but we will continue to learn from each other and look forward to inviting you again in the near future and hopefully see you in one of the meetings in a short time.
Well, thank you. I appreciate having the opportunity. Look forward to working with you and your colleagues. Please reach out. Anyone should feel free to reach out to me at any time if I could be helpful.
Thank you very much. All right.
Have a good night, everyone.
Bye-bye.